Hi, I'm Candice Silversides from the University of Toronto. I'm sorry I can't be there in person today, but I do feel fortunate that I can be with you today virtually. And so I'll be talking about pregnancy in women with the Fontan operation. I thought I would start with a case. So this is a case of a 23-year-old. She's had a lateral tunnel Fontan. She's well, she's on no cardiac meds. She's had no Fontan complications. She has good ventricular function, normal ventricular function, and no AV valve regurgitation. So if she came to talk to you about pregnancy, what would you tell her? Would you tell her she's at high risk for arrhythmias, for bleeding complications, for miscarriages? Would you tell her she's at risk for all of those above? Or would you tell her that pregnancy is contraindicated in the setting of the Fontan operation? So I'm going to come back to answer these questions in a bit. But just to start off, I want to remind everybody about the unique aspects of the Fontan physiology that could be impacted by pregnancy. So Fontan physiology has a unique cardiovascular physiology to it with both central and systemic venous hypertension. There's also non-pulsatile blood flow to the lungs. It's a preload deprived ventricle. And as a consequence of many variables, there's decreased cardiac output both at rest and with exercise. In addition to that unique cardiovascular physiology, patients may also have systolic or diastolic dysfunction. They have a propensity to arrhythmias, to thrombosis, and paradoxically to bleeding. And there also may be systemic manifestations of the Fontan operation, such as hepatic congestion or Fontan-associated liver disease, renal dysfunction, or neurodevelopmental issues. And you can envision that all these factors could be important when you add on a superimposed stress of pregnancy. So I'm going to focus on the cardiovascular stress of pregnancy, but there also is additional other physiologic stresses that may impact the Fontan physiology. But again, going back to cardiac physiology during pregnancy, there's an increased preload to the ventricle. You can envision that may be poorly tolerated in patients with significant diastolic or systolic dysfunction. There's also an increase in heart rate. As a consequence, there's an increase in cardiac output, again, that will persist throughout the pregnancy, and that may be poorly tolerated. Pregnancy is also a proarrhythmic state, in part because of the increased preload in both the atrial and ventricular stretch, but also because the hormones of pregnancy impact the action potential that may predispose women with Fontan circulation to develop arrhythmias, even if they have not had them in the past. Pregnancy is a prothrombotic state, and even outside of pregnancy, women and men with Fontan circulations are at risk for thromboembolic complications, and that risk is heightened during pregnancy. And also, there's, for many reasons, there's an increased bleeding risk during pregnancy, specifically at the time of labor and delivery. So you can envision all these physiologic changes related to pregnancy could destabilize an otherwise stable patient with a Fontan circulation, acting as a perfect storm to cause troubles. So let's talk about what actually happens in pregnancy. Before I talk about women who actually have a completed pregnancy, I do want to highlight that for reasons we don't fully understand, some women will actually have difficulty conceiving. And in fact, a significant portion of women will either not conceive altogether or have recurrent miscarriages. This is data from the United Kingdom, but what you'll see here is that only 42% of this cohort actually were able to conceive and have a successful pregnancy. So even before pregnancy gets completed, there's a increased risk of recurrent miscarriages and difficulties with fertility. I'm going to present data from this study. This was a summary of all the literature, all the case series of Fontan patients who had pregnancies and their outcomes. It includes more than 250 women who had a pregnancy. And if we look at the different types of complications, I'm going to break it down into maternal cardiac, maternal obstetric, and fetal and neonatal complications. So this first slide depicts the different types of maternal cardiac complications that occur in the Fontan population during pregnancy. The y-axis shows the rates of complications. What you see if you look at the x-axis is that the most common complication is actually supraventricular arrhythmias that occur in 8.4% of pregnancies. Almost 4% of pregnancies are complicated by heart failure, and 2% of pregnancies are complicated by systemic thromboembolism. In addition to cardiac complications, women are also at risk for obstetric complications. Really, this primarily relates to bleeding complications. You can see here the blue bar, which represents postpartum hemorrhage, occurs in 14% of pregnancies. 2.5% of pregnancies are complicated by retroplacental hematomas. These can be particularly problematic in women who require anticoagulation during pregnancy. And then finally, the red bar represents a premature rupture of the membranes. If you also look at neonatal and fetal complications, these occur with increased frequency in the Fontan population. In fact, these are the most common complications you see. The blue bar represents preterm deliveries, and almost 60% of pregnancies in women who have a Fontan operation have a preterm delivery, very common. Women also are at risk to have infants that are small for gestational age. Here it reports it at 20%. And the red bar represents neonatal deaths at 5%, which is very, very high compared to the general population overall. So they're not only at risk for adverse morbidity, but also adverse fetal and neonatal mortality. One way we classify risk is a risk classification called the WHO classification or the World Health classification. This was a 4-point classification system devised to assess pregnancy risk in women with pre-existing heart disease, with class 1 being the lowest risk or really no significant maternal cardiac risk, and class 4 being the highest risk where pregnancy is contraindicated. Women who are stable, otherwise well Fontans, are considered a WHO class 3 or a high-risk pregnancy lesion. And you can see the company they keep is with other complex congenital heart disease in terms of the risk class. However, women with Fontan operations who've had complications are considered WHO class 4, a risk category where pregnancy is felt to be sufficiently risky that pregnancy is not advised. So what makes a Fontan more high risk? Well, it's Fontans that either have systolic or diastolic dysfunction with heart failure. Those that have severe AV valve regurgitation may poorly tolerate a pregnancy if they have significant hypoxemia or refractory arrhythmias or more complex Fontan complications such as PLE. So if we go back to our case, I had originally described this otherwise very well 23-year-old lateral tunnel Fontan. And what I would tell her is that firstly, she may have difficulty getting pregnant because miscarriages are common. I would have mentioned that arrhythmias are the most frequent maternal cardiac complication and something we would have to watch for. Women are also at risk for bleeding, particularly postpartum bleeding, so that tends to be something we look for. And finally, that actually one of the biggest risks is actually the risk of fetal and neonatal complications, which occur with very high frequency in the Fontan population. Now, one thing that I would also address, not related to pregnancy itself, but related to life after pregnancy, is the fact that women who've had women and men with Fontan circulation have a decreased life expectancy. So this is just study from Gerhard Diller looking at mortality in patients with ACHD lesions compared to an age-matched population. What you can see if you look at a 40-year-old with an ASD, they have a mortality that's similar to a 42-year-old in the general population, but patients who have had Fontan operations when they're 40 have a life expectancy that's similar to a 75-year-old in the general population. So certainly women may get through a pregnancy, but this has major implications for them, for their children, and for their family going forward, and needs to be addressed as well. So if we go back to our case, what happened to her? Well, she did become pregnant. At 24 weeks, she presented with her first arrhythmia ever, an IART. It required cardioversion. She was started on metoprolol and low molecular weight heparin. She returned again with an arrhythmia. And in fact, she started to get destabilized at around that time. She had spontaneous rupture of her membranes, premature, like I've mentioned. Prematurity is a complication of the Fontan operation. She ultimately had a non-reassuring heart rate and required a cesarean delivery. The baby was fine. However, she developed a very large incisional hematoma, required fluids, had volume overloaded, and had a very prolonged hospital stay. So how do we manage complications during pregnancy? This is my last section of the talk. Well, first of all, arrhythmias are the most common, and interatrial reentrant arrhythmias are the most common of the arrhythmias that we see. They're poorly tolerated both inside and outside of pregnancy, and they can be associated with other serious hemodynamic complications. This is an old study I'm showing you here, but just showing you that when they develop arrhythmias, patients are also at risk for thrombus, for heart failure, and for other issues that need to be addressed above and beyond the arrhythmia. This is just a picture showing that really large atrium that you see, especially with old style Fontans, and the complications of the atrial thrombus that can occur. So I think it's just really important to remember that arrhythmias may be associated with important thromboembolic complications that you need to address if you're going to address the arrhythmia with a cardioversion. And so that really highlights this first point I've listed here, that arrhythmias may be an indicator of other hemodynamic problems, so you need to go looking for them. This is, again, not unique to pregnancy. However, probably, well, not even unique to pregnancy, is my second bullet, is that you should treat atrial arrhythmias promptly, try and restore sinus rhythm. I would say it's particularly important in pregnancy because you're not only dealing with a mom and a baby and you need hemodynamic stability, but it's also prothrombotic state, and thrombus and thromboembolic complications can develop very quickly. It usually requires cardioversion, in part because we don't have the full armamentarium of antiarrhythmics that we would have outside of pregnancy. So for instance, amiodarone is typically not used unless you really have to use it during pregnancy. All women should be anticoagulated, specifically during pregnancy, because it's a prothrombotic state, and EP should be involved because these are complex arrhythmias. Pulmonary embolus, I've already mentioned, can occur, although with less frequency than arrhythmias, in part because Fontan's a low flow state, but also because pregnancy is prothrombotic. Again, you have to go looking to make the diagnosis if you have any indication of symptoms that suggest a pulmonary embolus, and pulmonary embolus should be treated very promptly because it's very dangerous in the setting of Fontan physiology. There's variability on the use of prophylactic anticoagulation during pregnancy. I think there's some clear times where you'd anticoagulate if women have arrhythmias, if they've had a history of thromboembolic complications, if they have an atrium like the one I'm showing here that's filled with dense smoke. However, for a stable lateral tunnel or a stable extracardiac, I think there is variability from center to center about the need for routine prophylactic anticoagulation. And that is in part because there is this increased bleeding risk during pregnancy. And so you really do have to individualize and balance the risk of thrombosis versus a risk of bleeding. I've already mentioned that women can also develop heart failure. It's in part because they can have both diastolic or systolic dysfunction that can predispose to heart failure. If they do develop heart failure, especially in pregnancy, look for precipitants. The classic one is atrial arrhythmias, but things specific to pregnancy, like thyroid dysfunction, can cause arrhythmias or heart failure, and you should look to make sure there's no other precipitant that needs treatment. For those women that develop pulmonary congestion or volume overload, please remember that you can give Lasix during pregnancy, and these women should also be followed by an ACHD specialist, ideally one who also has expertise in pregnancy and heart disease. My few last points: in general, a vaginal delivery is preferred. There's less complications than a cesarean delivery. However, there are a few instances where a cesarean delivery is indicated in women with heart disease. It's not just having a Fontan operation. However, some patients with Fontan operation will develop premature labor while on an anticoagulant, and that's an indication for a cesarean delivery, because you can't do a vaginal delivery if the fetus is anticoagulated. For patients who have a vaginal delivery, not only do we do an early epidural, really make sure we do good pain management, manage volume closely, but we also assist the second stage to ensure that they don't have prolonged pushing. And finally, the last bit of management really relates to monitoring these women. You have to, because it is a preload dependent circulation, you have to be attentive that if they lose a lot of blood, it could really result in a cardiac collapse. However, you also have to finely balance it, because they'll often have IVs running and they can develop heart failure. And so you really have to find that fine balance between ensuring that there's enough preload, but not developing heart failure iatrogenically. And finally, I think I've already stressed you have to monitor for those other complications like arrhythmias and bleeding and thromboembolic complications even after the delivery itself. So I'm going to leave you with these 4 points. First of all, that the Fontan circulation is really a unique physiology, and that can be destabilized by those hemodynamic stresses of pregnancy. For those women that become pregnant, atrial arrhythmias are the most frequent cardiac complication, and they can also occur in conjunction with heart failure or thromboembolic complications or alone. Bleeding complications are also common, and that's what makes anticoagulation in this population more difficult than usual. And finally, fetal and neonatal complications such as preterm births and low birth weight babies are very common. Thank you very much. This is my cardio-obstetric team in Toronto that I feel very fortunate to work with, almost as fortunate as I feel to be able to speak here today at this really fantastic meeting. So thank you very much. Enjoy the rest of the meeting.